All right, folks, thanks for tuning in tonight, and it's the first talk of 2023. I'll be looking at our screen across from here, but at the end of the discussion, I'll be looking back over here to take the questions. If I look a little bit different, it's my winter beard that I'm growing out right now, and probably to horrify my kids and my wife. But that being said, I will go forward and introduce our topic. This is latest treatments for heart valve problems, emerging structural heart procedures. So, background. I'll be talking about our screen across from here, but at the end of the discussion. When we talk about heart valves, there's 4 major heart valves in the heart. And tonight, we're going to talk about 2 specific heart valves and 2 specific conditions affecting them. One will be aortic stenosis, which is basically a condition where the aortic valve gets calcified and stenotic, we call it, and doesn't open well. And the other one will be talking about the mitral valve and about a leaky mitral valve, which is called mitral regurgitation. The reason why I'm emphasizing these 2 issues is because a talk on all valve disease would take on all night. And I feel that the 2 conditions I'll be speaking about affect millions of Americans. So I think it's very important that we isolate some of the topics we can talk about more in depth. So the background. Historically, a number of cardiac conditions could only be treated with open heart surgery. Given the increasing age of our population, in addition to multiple comorbid issues involved, the risks of complications of operating on this population has also gone up. So we know in the last 20 years, medical technology has made leaps and bounds, and in the last decade especially, in regards to treating cardiovascular disorders. So let's go back in history. 30 years ago, we started using coronary balloons, which was basically revolutionary, that we would be using balloons to open blockages in arteries. This was followed by stents, and this was actually very effective to treat heart attacks, because we used to treat heart attacks with just blood-thinning medications. We weren't even putting in catheters, so it really changed how we were doing things. Pacemakers, which were implanted without open heart surgery, changed the dynamic of heart rhythm disorders. But the one area that cardiology and surgery hadn't really addressed was how do we address valvular heart disease without opening the chest. So we have a structural heart revolution. It's a revolution, not just evolution. So we now have the capability to address serious internal cardiac issues with minimally invasive techniques. So the results with certain procedures have now been shown to be equivalent, if not better, with certain conditions and surgical standard of care. The movement only seems to be gaining strength with newer technologies entering the cardiac arena every year. So first, let's talk about mitral regurgitation. So the mitral valve, simply put, is a valve that connects the left atrium and the left ventricle. So when the mitral valve becomes leaky, we call it mitral regurgitation. This condition affects thousands of Americans, vastly undertreated, and basically means the mitral valve has become leaky. Blood spills backwards into the lungs rather than going forward into the left ventricle as a result of a weak or degenerated mitral leaflet. This results in progressive shortness of breath, fatigue, and eventual heart failure. So there's different causes for mitral regurgitation. You could have something called degenerative mitral regurgitation, secondary to basically the valve deteriorating from infection or a heart attack that may have caused it. There's also torn cords. As you can see, these leaflets are attached by things that we call chordae tendineae. Functional MR, which is known as secondary MR, is a result of the left ventricle getting big. So if you start developing heart failure from other causes, you can pull apart the mitral valve, and that can result in a leaky valve as well. As you can see in the diagram there with the pictures, that just shows you how the mitral valve can actually get distorted with different conditions in the heart itself. So moderate or severe valvular disease is common and increases with age. Mitral regurgitation is the most common type of heart valve insufficiency in the US. So its prevalence increases with age from 0.5% for 18 to 44-year-olds to rising to nearly 10% for ages over 75 years old. So this is the vicious cycle of mitral regurgitation. Once mitral regurgitation starts, what it does, it basically makes the heart work harder to pump that blood out. So what that increasing load stress does, it actually damages the muscle in the heart. That dysfunction eventually leads to dysfunction of the left ventricle itself, which leads to the left ventricle then dilating, which then leads to more leaking of the mitral valve. If this is untreated, the 1-year mortality for severe mitral regurgitation is up to 57%. So the treatment, historically only medical therapy, which is basically including water pills like Lasix or blood pressure control, were the gold standards, and surgery obviously would be the standard if the patient can tolerate it. Surgery is still the gold standard. If a patient has a leaky mitral valve and cannot tolerate medical therapy for whatever reason, surgery still has an excellent role in treating these patients, whether by robotically or traditional open heart. However, surgery in certain patients can be high risk and needs to be done by the surgeon with the skill and experience to perform a mitral valve replacement or repair, more or less. At Boulder Community Health, we are pleased that our surgeons perform repair of the mitral valve surgically really quite commonly. Replacement is not done as commonly as other sites because the repair is more skill entailed and it takes more time and effort, and our surgeons can do it. So I am proud to say that when we do have these patients, they can get the cutting edge therapy here from our surgical staff. But for patients who cannot get surgery, and now when you ask, you're probably thinking, well, wait a second, who can't get surgery? Well, I'm talking about the patients that are older, more frail, have a lot of other issues ongoing that would make any type of open heart procedure basically a little bit more risky. So what we've developed in medical technology is something called the MitraClip system. The MitraClip is a minimally invasive system, and if you can see there, it's literally what it says. It's a clip. It's a clip that will go across the mitral valve and basically stop the leaking that's across the valve. But again, me describing it doesn't do it justice. We're going to take a look after this next slide of what the images of the video looks like. But with a MitraClip, we have seen that patients can actually have quick discharges to home, have the patients have a reduction in hospitalization, and again, an improvement in symptomatic relief. So with that, we're going to go ahead and show you what the MitraClip actually does, and I will walk you through the video as there won't be any sound and I'll be talking throughout. So that is not the actual size of the MitraClip, so nobody worry at home. It's a lot smaller than that. So there's your beating heart, and we'll go through some diagrams and showing you the anatomy of the internal heart structures. So you can see there the right atrium, left atrium, right ventricle, and left ventricle. What you're seeing there is blood being pumped into the left atrium in the right upper corner from the pulmonary circulation through the pulmonary veins and going into the left ventricle. This is how a normal heart should function. That flap area is the mitral valve. So that's what you see right there functioning normally in this position. Normally, the mitral valve takes blood from the left atrium on top, delivers it to the left ventricle below it. And this is the normal cardiac cycle of how blood is then pumped from the left ventricle out the aorta, which is basically on the left side of your screen. That jet, or that area that looks like almost like lava, like a volcano, that's mitral regurgitation. That is the essence of flow going backwards from the left ventricle back into the left atrium. So here on the left, degenerative mitral regurgitation is basically looking at the valve that's not really coapting. We call it, it's not connecting properly because there's something wrong with the leaflets themselves. This is a microscopic view of how the chordae have on a microscopic level some scarring already developing. And on the side of the screen here now is the MitraClip itself. So what this device has been developed for is to basically be introduced through the groin, which is in the area of the waist, into the femoral vein. This catheter is then inserted after local lidocaine is administered. There's no cutting of the groin to put this in. It is inserted and then goes into the heart. And then once it enters the heart, it crosses over from the one septum to the right to the left. This is not felt by the patient. Once this occurs, the device is then advanced over a wire. We then remove the dilator sheath, and then we introduce the MitraClip itself. This is such an ingenious device, it can actually bend 90 degrees and even further to get above the mitral valve. Once it's above the mitral valve, we try to isolate under echocardiographic guidance where the biggest leak is present. We then advance the clip across the valve, and once we find a spot that we feel would be sufficient, we pull back and we place the clip. And if we do not like the position of the clip and feel like, well, it's not proper, we could actually remove that clip and place it in a different area. So here we still see a significant leak by the clip. The clip will be opened, moved slightly, and re-grasped. Once we're happy with the grasp, we then release the clip. And the clip itself will then theoretically reduce that significant leaking of the mitral valve. And it's a permanent structure at this point. The clip will be in place. And we can exit out of that, please. And for the sake of time, I'm going to move into our next subject, which is the aortic valve. And I'm going to talk about aortic stenosis. So the last topic was mitral regurgitation, which was a different valve that was leaking. This is about the aortic valve, and we're going to talk about stenosis, which means it's not opening. This condition can be seen earlier in life as a congenital issue, like a bicuspid valve, but it's more often seen as a calcific age-related issue. So calcific aortic stenosis is a very real problem in the United States, resulting in closure of the aortic valve, which causes progressive angina, which is chest pain, lightheadedness, and eventual heart failure. But I'm going to tell everyone at home, these are not the conditions we look at right away. Rather, these are the conditions that happen later in the game, later in the process. Oftentimes, patients who have severe aortic stenosis will present with fatigue, tiredness doing their day-to-day activities. That will be usually the first type of symptom. From there, patients then develop potentially shortness of breath. Then you can start seeing the chest pain, the lightheadedness, and then eventual heart failure. So I don't like waiting to these occurrences. I like to say to patients, what is actually happening today? Can you walk that flight of stairs like you did 6 months ago? And if the response is, you know what, I'm just getting older, sure, you are. But is it your knees or is it your chest that's telling you you can't walk that flight of stairs? So it's an important distinction when we talk to patients about this condition. So the prevalence of aortic stenosis. It's estimated to be prevalent up to 7% of the population over the age of 65. It's more likely to affect men more than women. 80% of adults with symptomatic aortic stenosis are male, but again, I often feel that medicine's biased to males in the sense that we don't research a lot of females historically. So I still feel like there is a percentage of females out there who just don't complain enough that most likely can have these conditions. What's the demographics? So aortic stenosis can affect 2% of the US population over 65 years old. Sclerosis, which just means there's a scarring of the valve, but it hasn't reached the tightening, is 29% of the US population. So we know that with sclerosis, which is basically some scarring of the valve, there's a 50% greater risk of mortality and heart attack. And we know that aortic sclerosis progresses to aortic stenosis in 9% in over 5 years. So what is the cause? I have a lot of people that have come to me and said recently, I'm going to stop taking my calcium supplements because I've heard calcium can lead to more aortic stenosis. There are some small studies here and there that may link calcium intake to aortic stenosis, but to be fair, I have yet to see any tangible data or evidence to say that milk intake or calcium intake is directly related. So for anybody who has osteoporosis and taking supplements, keep taking them. We don't really have an idea if calcium intake has any bearing on aortic stenosis, but we do know it can be age-related, and the vast majority of the people over 65 who have it, it's related to that. We know it's related to infection. If you've had rheumatic fever as a child, you can develop aortic stenosis later in life. And of course, we know that people are born with a congenital bicuspid or two-leaflet valve that can lead to early stenosis in your 50s or 60s. So major risk factors: your increasing age, male gender, high blood pressure, smoking, and some elevated lab tests. But to be fair, these are not specific for aortic stenosis. If anything, if someone showed me this slide, I would say it's specific for all cardiovascular disease, because if you smoke and have high blood pressure and you're increasing age, chances are you're going to have some type of cardiovascular risk factors or disease. So this slide, I feel, is probably the most important slide of everything I'm going to be showing about aortic stenosis. So I want everyone to really pay attention to this. The fact is, aortic stenosis often presents later in life. So I would see a 70-year-old, 80-year-old, 90-year-old patient who will say, okay, well, I've had this all my life. Why is the concern now? Why do we have to do something now? Well, the reason is it takes decades for the valve to get to the stenotic area where it causes dysfunction. But see there at the latent period, once severe symptoms start, look how fast, not feeling that bad to severely symptomatic. Survival after the onset of symptoms is 50% at 2 years and 25% at 20% at 5 years. What that means is once you have severe symptoms, the curve to pass away, to die, is very, very dramatic. So hence, we don't want to find patients who say, you know, I'm a little fatigued, I have severe aortic stenosis, I'll just wait till I get worse, because then things become much more difficult to treat. Surgical intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. And that's when the historical teaching has been, when symptoms occur and you have severe aortic stenosis, we should move to do something to fix it and not wait till you have severe chest pain, lightheadedness, or heart failure. Here's a sobering perspective. 5-year survival for things like breast cancer and prostate cancer are way higher, maybe 5 to 10 times higher than severe inoperable aortic stenosis. Why is that? Well, because a lot of patients who have severe aortic stenosis present later in the game. Sometimes they present with severe heart dysfunction, so they're becoming too high risk to operate. And I'm stuck here, folks. Can you move that slide forward?
Should be good now.
So aortic valve replacement greatly improves survival. So the truth of the matter is, if you catch patients with severe aortic stenosis, symptomatic severe aortic stenosis early enough, people do well. This is the issue though. When you see that patients get treated early, they do wonderful. You can see there in the slide that it's really critical that the early recognition of it is pivotal. However, and I think we're stuck one more time. The low percentage of aortic valve surgery here shows you that when patients are not operated on, well, then you have a situation where that they obviously become quote unquote inoperable. And this is what we saw in the last 50 years. We've been seeing more and more of this. So the problem was when we have patients that say they were inoperable, surgeons were then left with, well, what do? Medications don't really work with severe aortic stenosis because it's a tight fixed orifice. So we had a situation where medications were very good. Surgeons were hesitant to take a lot of these high risk patients on because their outcomes were not good. So we had to do something in the middle. And just like MitraClip emerged to help patients who were just too high risk, there was a development of a new procedure. But first, we know, like I just said, open heart surgery became riskier with the older population. We know that people who get open heart surgery have longer hospital stays, rehab, and there's other comorbid issues. So in the last 10 years, there's really been a revolution. And that revolution has been called TAVR, transcatheter aortic valve replacement. It's called TAVI in Europe, transcatheter aortic valve implantation, and that's just a billing issue from Europe to here. Same thing. TAVR, TAVI are the same thing. So what is it? It's an aortic valve replacement as an alternative to traditional open heart surgery. It's less invasive, and it's historically was considered for patients who are too high risk for traditional surgery. However, in the last 3 years, we've seen that this procedure now has been offered for more and more population. And not just that, the TAVR options, when initially it started just with the Edwards Sapien valve, we now have 3 commercially available TAVR platforms in the United States. The Edwards Sapien, the Medtronic Corevalve Evolute, and the Abbott Portico, which the Abbott is only reserved for high-risk inoperable patients currently because it's the newest one to the bunch. So when you have these choices, how do we decide which is the best for the patient? Well, I will tell you, the data for specifically that Medtronic Corevalve Evolute has been phenomenal. We have seen such a flurry of data over the last 5 years especially that's shown that this valve can actually compete with a surgically implanted valve when it comes to deterioration of these valves. Actually, our own partner, Dr. O'Hare, had just recently published and was seen in the Daily Camera recently with his article about the Medtronic Corevalve actually outperforming surgical implanted valves in a large study all over the world, which basically show that the structural deterioration of a surgical valve is faster than with this type of valve. So we are seeing excellent data with this particular valve that we are utilizing. So we are now seeing data with this particular platform better than surgical valves, but we're also seeing them be utilized in high-risk populations, intermediate populations, and now low-risk trials that were recently revealed shows that TAVR can be utilized in low-risk patients as well. So at this point, I want to show the TAVR video to show you all exactly how we deploy this device. So once again, we have the beating heart. And once we make it, that's your aortic valve that's looking right in front of you right there in the middle of the screen. The aortic valve usually has 3 leaflets, and this is an image of it after calcium is deposed. You see it's not opening up as well. So with that being said, we then approach this the same way as we do the MitraClip, but with the exception that with the MitraClip, we go through the vein. With TAVR procedures, we actually perform all of them through an artery. So you can go through the artery in the groin, you could go through the artery in the side of the chest or space between the ribs. And there's one that's not even mentioned here, which we use here regularly at Boulder, which is going through the neck, the carotid artery. And we are actually doing so many through the carotid artery so well that it's actually being something that we are priding ourselves as being one of the centers of excellence doing that procedure in that method. So we place the valve across the stenotic valve across the wire, and while the heart is beating, we deploy the valve. And just like that, the valve is functioning on pressure alone. There's no sutures or needles or anything else that needs to be done. And the valve is immediately functioning at this point. And the patient is not on a bypass machine, nor using general anesthesia. Usually it's really just oral anesthesia, the gas anesthesia or IV anesthesia. And at this point, we close up our groin sites or whatever sites we are utilizing, and the patient's usually up and about in 6 hours after the procedure and home within 24 hours. So in summary, I want to say that heart valve disease is growing in the US population. We need alternatives to standard surgical therapy for patients who are at high risk for complications. So both TAVR and MitraClip represent the forefront of these therapies, but they are certainly not the last. And hopefully by the time we have a next talk with you, I can actually present some more of these new cutting-edge innovative devices. But for today, I'd like to start that conversation with the 2 mainstay devices for these 2 conditions. And with that, I'd like to say thank you, and we'll open the floor up to questions.
Thank you very much. That was very informational. We appreciate that. We want to remind our audience that now is the time for questions. And so if you have some, please put that in the chat box below the video, and Dr. Iyengar will get to as many as he can tonight. We have one person here that wants to know what material is the mitral clip made of?
So the mitral clip there is a cloth that's part of the clip itself, but nickel titanium nitinol is what we call it, is the makeup of the device. So people who have metal allergies, for any device, to be honest, orthopedic or cardiac, it's important that they let the physician know beforehand if there's been any issues, because we could always check for a metal allergy prior to putting this device in. But it's not the mitral clip does not have any animal product.
Okay. Can you remind me of the recovery time involved with the Medtronic procedure?
So TAVR procedures generally take about an hour to 2 hours to do, and the recovery is anywhere from 3 to 6 hours, and you're staying definitely one night in the hospital. Vast majority, I would say 95% of the patients we do perform TAVR on are discharged within 24 hours. The other 5% usually stay another night.
Okay. Can you talk about insurance coverage for each of these procedures?
Definitely, and insurance does cover both procedures 100% because they are both FDA-approved procedures. These are not research procedures, or they're not off-label. As long as we have the documentation, which we always do prior to doing these procedures, insurance has no issues in reimbursing for them.
Okay, that's good to know. How does one prevent heart valve disease?
So there's not really any way to prevent aortic stenosis in the sense that it is a oftentimes calcific disease that's progressive. Mitral regurgitation, however, if you have high blood pressure, that is the first thing I would say. If you want to prevent your valves from leaking, that's the one to do, is to hit your blood pressure. Make sure you check your blood pressure, keep it controlled, because controlled blood pressure, I've had patients who have severe mitral regurgitation who've reduced their blood pressure 20 or 30 points from like 150 or 160 systolic down to 130, 120, and their mitral regurgitation has improved, if not gone away. So you can do that if you control the blood pressure. So I think a lot of people hate talking about blood pressure. They always say it's only high in the office because I'm in front of you, but I will tell you, check it at home and verify that.
So kind of to that point, when you were talking about aortic stenosis, you mentioned some symptoms. You mentioned lightheadedness and some other symptoms. How do you know if it's aortic stenosis or if it's blood pressure or something else?
And that's the thing, is when someone says, well, one symptom is not going to be linked only to one type of condition. So you have to, number one, see your doctor. And remember, the big thing is not just the physical exam, but the history. If someone indicates they're getting lightheaded every time they stand up from a seated position, that could just be that you're dehydrated. It may be that you have too many blood pressure medications on board. So having someone listen to your chest, hearing a heart murmur, someone actually ordering an ultrasound, like an echocardiogram, to see if your valve is opening. But the basics are the history, and then the doctor listening to your chest and hearing that classic murmur to then understand maybe there's a connection between the symptoms and the valve.
Okay. Is TAVR the same as valve and valve?
So TAVR is not the same as valve and valve. What does that mean, valve and valve? Valve and valve is a situation now we've developed in our vernacular about if you have a surgical valve in place and that surgical valve is not working, instead of repeat open heart surgery, we can now put a TAVR valve in that surgical valve. And we call that VIV, or valve and valve TAVR. Or we can, just saying this not to confuse our listening audience or watching audience, but if you have a TAVR valve that doesn't work, you can put another TAVR valve in that TAVR valve as well, and that's called valve and valve TAVR. So that term, that phrase, is now being used more and more because we're seeing more surgical valves from years ago that have gone bad, and patients are older, so instead of subjecting them to open heart surgery, we can do a TAVR in that old surgical valve.
Does it last forever?
Nothing lasts forever. I will tell you that the only valve that can last theoretically through your whole life is a mechanical valve, which is one that requires you to take blood thinning medication like warfarin or Coumadin for your whole life. The problem with those valves, of course, are that people get older, they bleed more. So we are dealing with mechanical valves being less utilized because people are living longer. Both the surgical bioprosthetic valve and a TAVR valve use animal tissue. Animal tissue will eventually degenerate. So we are looking now at surgical valves sometimes lasting as low as 5 years up to maybe 20 years. The data for TAVR, especially the Evolute, what we just showed you, the Medtronic valve, is out nearly 10 years. But remember, the valve's only been in existence for approximately 10 years.
Can TAVR be used for aortic regurgitation?
That is the hot button billion-dollar question for 2023. For the last 5 years, people have said, well, if I treat one condition with it, why can't I treat the other common condition? Well, this is the reason. When you put up a house, and I'm not a builder by any means, so anybody watching who says that's ridiculous what he just said, I'm just going to give you a base analogy that I think is appropriate. You lay down concrete. Concrete then builds the structure above it. The thing with aortic stenosis, the valve acts like concrete and holds the TAVR valve in place because of the calcium. If you have a leaky aortic valve, you put a TAVR valve in there, that TAVR valve is going to do this. It's like putting a house on quicksand or on soft ground. So right now, we do not have a TAVR valve that actually can sit in a leaky aortic valve and stay properly. There are many studies being done, and there is a valve in Europe that they're using right now that might come over to the US, hopefully in the next year or so, that may be used for leaking aortic valves.
Can a mitral clip be used on a patient who has already had a valve repair?
So another excellent question. So yes, but this is a caveat. When someone has had a prior mitral valve repair, a surgeon will oftentimes take a piece of one of the sides of the leaflets off. So instead of the leaflets like this, the leaflet will be this. And what you have here is a smaller part of a leaflet. So you cannot put a clip where there's no leaflet. So it depends on how that prior surgeon had performed the repair, if they left enough for it to be clipped.
We'll see if I can pronounce this one. Can this procedure be used for ectasia ascending aorta?
So for an ectatic ascending aorta, so these procedures are not utilized for a dilated or ectatic ascending aorta. Unfortunately, there is no endovascular or percutaneous, which means minimally invasive therapy for a dilated ascending aorta at this time, right now. Are there studies looking at that? Yes, but the problem is, if you have a dilated aorta, it attaches to the coronary arteries to your heart, and it's very difficult to put a graft or something there to fix that without blocking those arteries. So currently, open heart surgery is still the standard of care for a dilated ascending aorta.
Is there any impact to your daily life after having either one of these procedures? Can you still go walking? Can you still
That's the whole goal.
stairs?
Absolutely. The goal of these procedures. Now, again, I have to preface this. There is an expectation from patients oftentimes to say, I'm going to get this, and I thought I was going to be 20 years old again, or I thought I was going to run that marathon or the Boulder again. If you're 80 and you're not running the Boulder, this is not going to make you 20 to run the Boulder. So I try to tell everyone, yes, the expectation is to feel better, not be admitted to the hospital, hopefully live longer. But the truth is that it can't recreate what you had 50 years ago. So I think there is a realistic expectation here that we have to tell patients, this procedure is not just to make the valve better, but to make you feel better. But oftentimes, if you have COPD, if you have other issues with arteries in your heart and other places, there's other problems that are going to be associated with it that we can't fix with just one procedure. So that's why I try to be very clear, because I think a lot of people look at this and say, wow, this is a neat procedure, but how come it didn't fix X, Y, and Z or fix everything? And it can't. There's no such procedure that can do that.
Is there physical therapy that's required?
There is no physical therapy or cardiac rehab. We suggest every patient to do cardiac rehab because we think it's great, and I think patients really benefit from it, but it's not mandatory.
Can you go into what cardiac rehab is?
Cardiac rehab is basically a rehabilitation center specifically for cardiac patients post open heart surgery or post TAVR or MitraClip or even heart attacks. Patients who've had a cardiac procedure. They go to a supervised facility where you have exercise physiologists, physical therapy, watching the patients, monitoring their heart rate and their blood pressure while they're exercising through tailored sessions for these patients. It is excellent. I suggest that every patient that has the opportunity to do it should do it.
And that can start immediately after the surgery?
Exactly, absolutely.
Can this procedure be used for, I just said that one. What is the life of these devices? How often would you need to have it replaced? You mentioned 10 years is what you're studying. Is there anything more you can add to that?
Actually, no, because the device has been, at least the TAVR valves have only been in the US as an FDA approval since about 2011, 2012. So we're looking at just over 10 years. And in the 10 years, the valve itself has changed multiple iterations. So the best data we have is the one that I showed you on the video. 10 years though, at this point. So we don't say it's 10 years, we just say we have data up to this point. For the MitraClip, that's a lifetime procedure. And there's no indication that we'll ever have to replace a MitraClip from wearing out because there are no animal products to degenerate.
Is a heart murmur the beginning of a valve problem? And if so, is there any preventative measure?
So a heart murmur can be the start of a valve problem, but it could also be innocent. We also know a lot of times here in children, innocent pediatric murmurs. It could be just the flow of the heart. When the heart beats, the flow outside of the aorta, coming through the aorta could cause a murmur as well. So a murmur does not indicate a heart valve problem. Heart valve problems have murmurs though. So the truth is that there's no real way to say, oh, I have a murmur, I now have a problem. You may not. You would need to have, number one, a good physical exam, and number two, which we suggest for all patients who have new murmurs, an echocardiogram to assess. And there's no real way to avoid having this murmur. There's no way to really say, well, I don't want a murmur or a heart valve problem. What do I do to avoid it? The ways to realistically, if I had to tell anybody out there, if you're getting any type of dental work and you have an infection in your mouth, well, take care of it earlier, not later, because that can get into your bloodstream and affect the heart valves. Obviously, drug use, IV drug use can cause heart valve problems. Rheumatic fever as a child can lead to heart valve problems. So any infections in the body can seed in the heart, and that can cause these issues later in life.
Do you have any information that's a little bit more current on COVID impact?
So we have not seen anything with COVID and valvular heart disease per se. We have seen, though, a lot of COVID infecting the pericardium, the sac around the heart, causing inflammation, causing pericarditis or myocarditis. We've seen COVID affect blood clots in the heart or around the heart. That's been something we've seen. But in valves, we have not seen COVID with a direct relation to that, or at least I have not.
Okay. What is available with valve replacement repair for aortic regurgitation?
So surgery currently is the gold standard for a leaky aortic valve. Again, there are trials in Europe currently, and here as well that are trying to get up and running for valves that may be implanted for aortic regurgitation like TAVR, but it's still not ready for prime time. We still don't have the data for that. It's something I anticipate hopefully within the next 2 years to be available if it is a positive trial.
Can you talk a little bit about how that works as far as Europe being successful or having good data on that, and then how it moves to the US?
Well, usually when Europe has, or even Asia has success in any type of technology, our FDA, rightfully so, they scrutinize these things heavily because they feel that, okay, well, they did it there, but it doesn't mean we can just take it and bring it over and start doing it here. What happens is if the data does shine positive in another region of the world and comes to the United States, and again, the companies have to bring it here, a trial has to be done first. Once the trial is done, we call it a feasibility trial, it then gets bigger into a randomized trial. So these take years sometimes. But again, it's done for the right reason, because the last thing we want to do is start putting things in people, finding out 3, 6 months, 1 year later that they stop working. So that's why these take so long to come to fruition. Okay.
Thank you for explaining that. Can the mitral valve clip move later and travel in your blood vessel?
So it can move. We call that a single leaflet detachment, but that doesn't happen later. That happens usually on table or within the first 24 hours of the procedure. That doesn't happen anymore as much as we saw 10 years ago. When we first started doing these, the clips were different. The clips that are now implanted are much more, they are accurate, precise. The clips themselves, the arms are much more tighter. So, and if they're done well, and again, it is a person putting it in. When I'm putting these in, we don't release until we're 100% sure it ain't gonna move. So I can tell you for a fact here in Boulder, we've never seen it here, but in my history in the past, I have seen it in the past, but it was an older generation of these devices. So we aren't seeing it here, but we had seen it in the past. So it is something we are well aware of.
Okay. Good to know. Is there dementia associated with complete aortic stenosis?
Well, go ahead.
This person is asking because their mom was diagnosed 4 years before the valve failed and now is older, 96 years old. Any ideas?
So that's how the truth is that when you have vascular disease or a calcified disease in your valve, there's always a chance you have calcified disease in your arteries, in your head and neck. And it may not be in your carotids, but it could be in the brain. And when you get to that age group, if there's less blood flow coming out of the heart, there's less blood flow going to the brain. So that could actually lead to what we call a watershed type situation where there's just not a blood flow to the brain and the brain arteries aren't getting perfused. Hence, that could lead to vascular dementia. That's one of the terms we use. And it could also be a relation to that, could there be calcium from the valve that's already in the brain? That could be occurring as well. So it's not a one-to-one correlation that aortic stenosis leads to dementia, but when someone has severe aortic stenosis and they're that age group, it wouldn't surprise me if there's calcium in the arteries of the brain as well.
Anything they can do?
Once dementia at that age group occurs, it's very unlikely that by fixing the valve, it's going to change that underlying pathology.
Thank you. Is a heart murmur the beginning of a valve problem? And if so, are there preventative measures?
I think we already asked that. We answered that question.
Yeah, I think we've had that. Just 1 second, please. Could you please discuss the process for testing patients as to candidacy for TAVR?
So the first and foremost thing comes down to the patient, to you, the most important thing. So when someone says, hey, you know what? My primary care said I have a heart murmur. It sounds pretty harsh. They wanted me to get further evaluated. So that's usually how they end up in our office. So once they see me, we'll sit and talk. We'll say, okay, let's talk about how you feel. What's going on? And if someone says, 6 months ago I was walking up the foothills and now I can go up, but I have to stop about 4 or 5 times, but that's okay, but I still get up to the top. That's important to figure out, okay, so there's been a change of lifestyle over a few months or a year. Second thing is listening to the patient. If the murmur's real, you're hearing it, okay, we have a murmur, we have some symptoms, let's figure out, let's put them together. The next step is getting the ultrasound, the echocardiogram would be the next step. If that verifies that the valve is not opening, and then we have certain criteria of numbers, we call it the aortic valve area less than a centimeter, or the mean gradient across the valve of over 40. These would be indicative the valve is entering a severe level. So once you have that finding on the echo, coupled with the symptoms, then we call that severe symptomatic aortic stenosis. And then the conversation then goes to what do we do about it and how do we make sure that we can honestly address this head on. I have plenty of patients that have the severe aortic stenosis, but they're running up the foothills every day and they don't complain. Those are patients we continue to keep a very close eye on and make sure that once symptoms start, we can then address it. I have other patients who have tremendous symptoms, but their aortic stenosis isn't that bad. So we need to investigate these patients further by saying, is it another valve? Is it your lungs? Is it your arteries? Is there something else causing you to feel this way? Because your aortic stenosis isn't that bad. So that's why it takes an investigation before we say it's just these two things that can cause it.
Okay. That's the tricky part.
It is, but that's the art of medicine. And that's why I feel that it's important that we don't just have a knee-jerk reaction and say, oh, you have aortic stenosis, you get valve. It doesn't go that way. I think it's important that we figure out that, hey, maybe your valve isn't the problem. Maybe there's something we haven't even looked at. You know, and oftentimes we do find things that you're like, well, I didn't realize there was a lung issue on top of the valve that may be contributing to what's going on.
Is there a typical time frame from when you run the test to when you can make that determination?
Almost immediately, to be honest. I mean, we do the after the echocardiogram is done and after I've met the patient and spoken with them, we can then reconvene quickly and figure out, okay, this is what we're finding. Let's move forward and make sure we're addressing the right problem. Because what we don't want to do, like I showed on that slide earlier on, once the curve drops, it drops fast. So we don't want to wait till someone says, I'm a little fatigued, let's wait till I'm really fatigued, because we don't know when that really fatigue is going to happen. And when it does happen, it could be really dramatic. And like I always tell patients, I have a lot of patients too that have told me, you know, I don't feel that bad, I'm a little short of breath, I don't really want anything done. And those patients are the ones at 2 in the morning in the ER, huffing and puffing, and almost go on a ventilator because they're in heart failure. And then they say, please fix me. So I always say, we don't want to be that guy at 2 in the morning. We want to be the guy in the office at 3 o'clock talking about it, you know, in an elective way.
Okay. Good to know that it's that immediate. Can a TAVR valve be used if you have a pacemaker?
So a TAVR valve can definitely be used in anybody who has a pacemaker.
How does the physician choose between the neck or the femoral artery for TAVR?
So the femoral artery is done in the US probably 98% of all cases. In the majority of cases we've done here at Boulder, I would say 95 to 98% probably as well. So why are we not doing 100% and why are we utilizing any other approach? Because not every person has the same femoral arteries. There are people out there who have tiny calcified femoral arteries the size of my pinky. There are other ones that look like the size of my arm. It's amazing how God has made us all so different. And I can tell you, I've had 6'3" males with tiny arteries and short 4'11" women with massive arteries. I can't explain it, but it happens. So there are times where we cannot use the groin arteries because of calcium or size. In those patients, we look for alternate approaches. And the carotid artery, amazingly, has become one of the most viable approaches to placing the valve. Now, again, it's a little bit more invasive though, because we are having the surgeon cut open the carotid artery to place the catheter. So it's more invasive than going through the groin. However, our results here in Boulder have been fantastic. So that's why I'm not hesitant to say, if someone doesn't have the access to the groins, this is a very good alternative for the patients. And again, it's one of those where you want to be able to offer patients multiple options, not just the one way of doing it. And I've actually, when I go around the nation speaking on these subjects, I tell everyone, the other physicians, be mindful that not every patient is going to have the same access point. You have to be able to be nimble and go other places if you can't go to the traditional way.
But that's usually determined pre-surgery.
Definitely pre-surgery. Absolutely. We plan out everything before we hit the table.
Perfect. Are pacemaker wires in the heart in the way of the procedure?
For the TAVR procedure, they are not in the way whatsoever. But for the MitraClip procedure, because we are going through the vein, they can be in the way to get to the left side of the heart. But in my experience, and I've done these since 2013, it's never been inhibited to the point we can do it. So they are there on the right side of the heart, but they have never stopped me from putting the MitraClip in.
Okay. Just 1 second, please. Can you provide a little bit of clarification about allergies to nickel? How do you fix a mitral valve that has a moderate leak?
So allergies to nickel, simple, we would get the patient to see an allergist. You know, there is importance right there. If someone has an allergy in the past, usually we hear from the patient that they said, hey, I had earring, I had some type of a prosthetic in the past, or I even had, like, I rubbed it across some metal and I've had some breakout. Those are the patients which we have an allergy testing through an allergist here locally. Once we get that performed, then we'll have a better idea of whether or not patients should be getting these prosthetics. For moderate mitral regurgitation, it's a little bit more trickier for what we do about these patients. Number one, you have to identify, is the blood pressure high? Is there something else causing that mitral regurgitation, like a blocked artery that's been, a heart attack in the past, or something else of that matter? If those aren't the issue, close surveillance of that moderate mitral regurgitation, depending on symptoms. Now, if someone's short of breath and has moderate mitral regurgitation, I might pull the trigger earlier and say, we need to have our surgeon see you, because we want to avoid that progressing into the slide I showed of the vicious circle.
We want to remind our audience that we can take a few more questions. If you have them, please put them in the chat box. What do you do if you have a leaky mechanical mitral valve?
So that is a lot more difficult. A leaky mechanical mitral valve, unfortunately, doesn't lend itself to any of the procedures I talked about tonight. Mechanical valves inherently are mechanical, so you cannot really put anything else in them because, again, they're all metal parts. So if a mechanical mitral valve is leaky, the leakiness is causing symptoms, unfortunately, the only thing to do would be to replace it surgically.
Going back to the trials outside of the U.S., then coming to the U.S., about how long does that usually take then?
Years. It is not a short process because, again, even if it's amazing data comes out of Europe, the FDA, and again, I keep emphasizing, rightly so, try to protect us. They're trying to protect everyone here from getting devices that may not work. So we are seeing at least probably 2 to 3 year process when things come from Europe before they're even commercially thought of being released. Because the trials, again, have to be overwhelmingly positive and safe for the FDA to approve.
Okay. Once a patient decides to do TAVR, what are pre-surgery procedures?
So usually if we decide to move for TAVR, first and foremost, what we would do is something called a heart catheterization. That's where I would put a catheter in the artery to look at the arteries of the abdomen and the heart to make sure the highway from the groin to the heart is open and basically able to take a TAVR valve. We also perform CAT scans of the chest, abdomen, pelvis to look at outside the vasculature to see if there's anything in the lungs, the liver, the gut, anything that we need to know that should be there. Because I'm going to be honest, I've done this for a long time, since 2007 with TAVR, and we have found when we do these CAT scans, we find things that people never knew they had, like malignancies that were undiagnosed. So we need to know that before we put a valve in, because again, the requirement for CMS, which is FDA CMS, is to basically, when we put a TAVR valve in, we need to make sure there isn't another condition that will be there that could potentially limit a patient's life, like a malignancy, if it wasn't diagnosed.
If you had an aortic aneurysm repaired, would this not allow you to be a candidate for TAVR?
So aortic aneurysm repair, we can definitely still, and I have, gone through the femoral arteries with these patients, and we've gone through the carotid arteries. So that is not at all a restriction for us to do the procedure.
And mitral valve repair is still possible after TAVR?
Absolutely. Mitral valve repair is going through a different vessel. So MitraClip or mitral surgery is basically completely different than a TAVR procedure.
Perfect. I think that's all that we have for tonight.
Excellent.
I appreciate all of that. I'm going to wrap it up here. We've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us and have a good night.